This is presentation number 4 in the series of the use of multi-detector CT or multi-slice CT in chest and abdominal emergencies. This one will be concerned with non-traumatic lesions. The other previous 3 presentations were concerned with traumatic lesions. It's prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. Examples of such things are the aneurysms, pulmonary embolism, air within the mediastinum or peritoneum, pneumomediastinum, pneumoperitoneum, esophageal perforation, caval obstruction, fibrosing mediastinitis, and some cases of pneumonias, especially those aggressive types of pneumonias, as in acute interstitial pneumonias, including pneumocystis carinii and viral cytoplasm, viral pneumonias, and as well as mycoplasma. These are the items we will be considered here. Of course, we will not include intestinal obstruction and ischemias. Classification according to Stanford: type A is involving the ascending aorta, type B is not involving the ascending aorta. According to Lebeki, type 1 is involving the whole aorta, type 2 is involving the ascending, type 3 is involving the descending. This is involving the root of the aorta, that means the ascending aorta. This is type 1 according to Stanford. This involving mainly the descending, and this is type 2 dissection with the flap, laminar flap, and here there is a flow within the aorta, and this is the blood clot around. Here we have aneurysmal dilatation mainly of the aorta, both ascending and both descending, but there is hematoma around, and this is due to rupture. The hematoma is well seen in the coronal reconstruction film here. Multiple ulcers along the aorta are seen. Aneurysmal dilatation is noted, and hematoma is formed around the descending aorta. Here we have the well-known tortuous unfolded aorta. Tortuous unfolded aorta, but still there is dilatation, irregular dilatation. That's why we can say that this is tortuous aorta with aneurysmal dilatation. Both are there. Of course, there is clotted blood around here and there. Now in this one, blood collects within the mediastinum, behind the pulmonary, behind the ascending aorta and pulmonary, and this is mediastinal hematoma due to leakage. Here we have the intramural hematoma. This is calcification. There is some increased density around here and some increased density here, displacing this calcification medially, that this is the appearance of intramural hematoma. Intramural hematoma typically extends over long segment of an aorta of normal caliber, whereas the thrombus is usually seen along a short segment of a dilated aorta. So what is the difference between hemorrhage and thrombus? Thrombus is usually focal, while mural hemorrhage extends along a long segment. The diagnosis of intramural hematoma requires visualization of the displaced intimal calcification or increased attenuation of the aortic wall due to blood density, both of which may be obscured if you give intravenous contrast. So if you give intravenous contrast, you might not be able to detect this intramural hematoma, which displaced the intimal calcification or causing increased attenuation of the aortic wall. So contrast will obscure such changes. These are examples of intramural hematoma without contrast. This one, that one, intramural hematoma. Blood is collecting around the true lumen. Blood is collecting and constricting the lumen. Blood is collecting, and this with contrast, and the blood is collecting around a long segment of the aorta, long segment of the intramural hemorrhage. Aneurysmal dilatation of the descending aorta. This is the one with intimomedial rupture of a dissecting flap associated with pulmonary embolism. So don't forget that you should check the pulmonary arteries as well for any emboli. These are the appearances of an ulcer along the aorta, something protruding, similar like that of the renal cap ulcer. It's a protrusion, another protrusion. These are examples of penetrating ulcers of the aorta, usually associated with intramural hematoma or surrounded with the blood thrombus. Abdominal aortic aneurysms, we should comment on the extension, whether it is infrarenal, renal, or involving the renal, means suprarenal. So the renal artery is very important to be checked, whether involved or not, and you should report that. So you have infrarenal, renal, and suprarenal, but sometimes a very long segment is involved, and the thoraco-abdominal aneurysm will be the report. Thoraco-abdominal aneurysm. Aneurysm is wide in the abdominal aorta, is widening above 3 centimeters. 90% of the aneurysms of the aorta, 95% of aneurysms of the aorta are infrarenal. This is the most common. When to consider an aneurysm? When the diameter is 1.5 the normal. Remember that the thoracic aorta caliber is 4 and actually 3.8 centimeter, does not exceed 4, and the relation between the thoracic and abdominal aorta is 1.5 to 1, while the relation between the ascending aorta and the descending aorta is in the range of 5 to 4. It should be less. The descending aorta should be less than the ascending aorta. Now these are examples of aortic aneurysms, dilatation of the aorta more than 3 centimeters, with atheromatous calcification, with hematoma around, and intramural hemorrhage. And this is collection retroperitoneal. This is pulmonary embolism involving the main pulmonary artery and its branches. And this is pneumomediastinum. Here the air is seen surrounding the mediastinal structures. And here we have the esophageal perforation with extraluminal extravasation. This is the esophagus perforated with extraluminal extravasation. Another emergency. This is the pattern of pneumonia you can find: streptococcal pneumonia, consolidation, and this is another type of pneumonia caused by staphylococcus. It's called bronchopneumonia because of patchy and multiple, and there is bilateral pleural reaction, and there is starting of an abscess. So bilateral is the start of an abscess. This is again bronchopneumonia, staphylococcus pneumonia, patchy, bilateral, with developing pneumatoceles and abscess. here is the appearance of influenza pneumonia. It should be considered as patchy multifocal ground glass opacity and should be differentiated for pulmonary hemorrhage. This is mycoplasma or aspergillus bronchopneumonia, predominantly peribronchial. Rarely it causes patchy areas of consolidation as this. So lobar consolidation, it is almost impossible to differentiate aspergillus bronchopneumonia from bronchopneumonia of other causes if there is lobar consolidation. It's similar to that here, to that one or that one. Streptococcus, staphylococcus bronchopneumonia, and mycoplasma or aspergillus bronchopneumonia will be the same if it is extensive lobar, and but it is predominantly involving peribronchial areas. Among the differential diagnosis which should be considered in emergency non-traumatic chest condition is the BCP, or the developing of the pneumocystis carinii pneumonia, in which you find diffuse consolidation with multiple cystic areas and multiple reticulations within the lung in a patient of AIDS. Thank you.